Hello, and welcome to another episode of Fertility Docs Uncensored. Woo! Yay! I am Dr. Carrie Bedient from the Fertility Center of Las Vegas. I am joined by my two delightful and completely far more sane co-hosts, Dr. Abby Eblen from Nashville Fertility Center.
Well, I don't know about that, but hi, Carrie.
And Dr. Susan Hudson from Texas Fertility Center.
Hey,
How
are
you guys
y'all?
doing?
Good.
Doing good.
Good. So we have been talking about all of the things of, spring, summer cleaning and going through and getting rid of the big things, the little things, all of that. And we started talking about what are the little things that you buy that feel like a total splurge. And I'm talking about like the $20, $30 things. I'm not talking about anything that's like super wild and crazy.
Not like a speedboat or something like that.
We're not talking about speedboats, diamond rings, or
Yeah.
mansions. We're talking about life's little luxuries. What kind of things do you get?
I have to make myself walk past Sephora or Ulta because I don't know. If I walk in that place, I come out with something, and it's usually something I never intended to buy. I don't know. I think I buy into the okay, this makeup base or foundation is going to make my skin look velvety soft, or this mascara is going to make my eyelashes look so much thicker, and and I get it home and it's really not all that after all. But I cannot walk in one of those stores without coming out with something.
What about you, Susan?
I mean, this is kind of like a little bit of a guilty pleasure, but it also like helps maintain my sanity and the sanity of those I come home to. So like I'm usually starving at the end of a workday. So if I'm starving and then I have to go to our grocery store and get food, which is going to take another 30, 45 minutes and then get home, I tend to be a little hangry by the time I get home. So what I have found is Hershey bars with almonds are a perfect blend, kind of like a small can of Coke. And I can have that in my car on the way home. And then I can come home and fix dinner and not be a grumpy person, which is a good thing.
Ah.
Do you have a redheaded temper, Susan, when you're grumpy?
I have a I don't do good when I'm hungry, and I don't do good when I'm tired.
Hi.
I wouldn't say I have a temper. It's just I have no tolerance for anything. Like I'm very short at that point. And I'm a very direct person to begin with, and direct plus short usually doesn't mix well.
Hey, on a side note, do you go for dark chocolate or milk chocolate usually?
Well, in that case, I'm going for milk chocolate because it's right there at the checkout line.
Okay.
I mean, I appreciate good dark chocolate, but
Okay.
that is not necessary for that moment of splurge.
Because as a side note, I just learned in doing some research for our upcoming book that THC in marijuana triggers the incanoid system. I can't remember what it's called, but also dark chocolate does too. So I'm like, that's why I like dark chocolate so much.
What's your guilty pleasure, Carrie?
So my hands are perpetually dry, both from scrubbing and from living in the desert. And so there is a lotion brand that my college friends sent to me. It was last year when like all hell was breaking loose in my life. And they sent me a care package, and it was dark chocolate. And it was one of those like head massager thingies.
Yeah.
And there was this bottle of lotion, and I'm kind of like, oh yeah, whatever. Like I see lotion come through. Normally I get whatever is the cheapest, thickest, whatever to go through to help my hands. And I love the scent of this lotion because it's so mild. Because I have allergies, I will sneeze at anything. And it's this Ecos Castanha. It's like based off of Brazilian nuts. I have no idea, but it's a very mild scent, and it's like 15, $20, which is way more than I would ever spend on lotion, because normally we're talking about the Vaseline intensive care, plain boring, whatever. But it just, when I'm in the middle of consults, I will put it on my hands, and then like just get that scent, and it helps keep me calm. And
Is
Ah,
it
that's
the one in the
cool.
little brown squeezy thing, or is it the orange, purple, or yellow?
it's the brown one. It's the hand cream. I just got the foot cream too, which is the in a silver squeezy thing. I honestly can't really tell much of the difference between the two, so I kind of default to the tannish brown bottle.
Very cool. It is available on Amazon.
Mm-hmm. Yep. True story.
But they do have a trio, so you can try out. Let's see, one's the hand cream.
And let's just
brown
point
one.
out they're not our sponsors, but but we really like them a
We are
lot.
not. Oh, there are 3 different types of hand cream if you get the trio.
Oh, I didn't notice that. I just get the one in the brown.
What's the name of this
brownish squeezy.
stuff? I need to get
It's
some then.
EKOS.
Ecos. Okay, good to know.
Yeah, it's just a very calming, very mild. It's not overwhelming. It doesn't set off my allergies typically, which is nice, but there's enough of a scent that just like, oh, okay, I'm having a spa day in the middle of my clinic and it's going to be great.
I just added to my cart.
Marvelous.
Wow.
Okay,
Deal.
so now that we have answered the all important question of what do you splurge on, do we have a listener question today?
We do. Hi, I just went through my first round and I didn't get the results I was hoping for. I am 29, AMH 4.5, hypothalamic amenorrhea since coming off birth control pills 8 months ago after 13 years. Lifestyle changes don't work. We want embryos for 2 to 3 kids and did 1 round of Gonal F, 150 to 100 units, Novarel, HCG 26 units, Lupron, and 1500 HCG trigger with estrogen over 10,000 and mild to moderate OHSS, 25 eggs, 22 mature, 19 fertilized with ICSI because low volume on the day, dehydration nerves, but great density. 4 were biopsied, day 6, 6 AC, 6 BC, day 7, 6 AB, 6 BC. I don't have a ton of hope for the day 7s, and even so, none of my gradings are great. 5 others were 6 AC, 6 BC, all day 6 and unable to biopsy because the trophoectoderm was fragile. What can I do to improve the next round? Should I use these?
That is a fantastic, totally loaded question.
There's lots to unpeel there.
Lots to unpeel there. So let's maybe start with FHA and STIM. So functional hypothalamic amenorrhea is essentially when your hypothalamus is not real interested in producing all of the signaling hormones. And so it's not that there's a deficiency, like it's not that there's necessarily a problem. It's just the instructions have not been sent out. And so the body does not know what to do. And so when I look at that type of protocol, the things that pop into my brain are that I would probably add, I like Menopur instead of Navarro a little bit more.
Me too.
And so I might gear a little bit more towards that. I tend not to find Lupron triggers super helpful. Like your maturity actually looks much better than I thought it was gonna, probably because of the HCG more than anything. And so I don't know that a Lupron trigger is as helpful, although because you had OHSS and such a high
But didn't she say she also got an HCG trigger?
1500, yeah.
1500
Yeah.
HCG
Yeah.
trigger.
So, I might consider if you're going to do another stim, backing off even more on your dose, adding in a
Maybe
little
doing 75
Menopur.
units of Menopur a day.
Yeah,
Yeah,
I would do that.
yeah, and I would say backing off a little bit when it comes to stim, so that you can get an HCG trigger without as much concern about OHSS. It feels counterintuitive to say give me less, but sometimes less is more.
Yeah, that's the scary part about patients with hypothalamic amenorrhea. I've had several people lately that have come through, and it's like it's the yin and the yang. They don't usually do great with Lupron triggers, but boy, it sure is scary to trigger somebody that's got 25 follicles, because back in the days before we did Lupron triggers, those were the patients that usually had high estrogen levels and usually got really sick. So it's really scary. But yeah, I think definitely doing 75 HMG. I always do that with somebody that has hypothalamic amenorrhea. But I think when you look at the number that fertilized, because at first I thought, oh, I bet she has a lot of immature eggs. You really didn't, though. You had 19 that were fertilized, so that means those eggs were mature, but you just didn't have good embryo development, and it's kind of hard to know. Or, well, I shouldn't say not good embryo development. Just I would have expected you to have a few more to test, maybe not a ton more,
Yeah.
But,
I would have
maybe
expected 6 to 7 instead of 4.
yeah, maybe just a little bit more, maybe the HMG might help a little bit because, if you could get 1 or 2 more embryos to test, that would be great. And it also took, I think you said a couple of them went to day 7, which is, I would agree, is a little bit late. It's not that we can't get pregnancies with day 7, blastocysts that are genetically normal, but they're less likely to conceive, or you're less likely to conceive with those. So I think just some minor tweaks would be helpful, but we do see with a lot of patients, even if you have hypothalamic amenorrhea or you don't, we see sometimes a lot of eggs, and that doesn't really always extrapolate into a ton of good genetically normal blastocysts. But I do think there's some tweaks that can be made, and I think it will help.
Right. So I have 2 things to say. So first of all, her last question of should I use these embryos if they're normal? Yes. Yes, 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 yes.
Absolutely.
There's no reason not to use them.
100%, yes.
Okay.
Definitely.
So definitely use your embryos if they're chromosomally normal, if you choose, or if you're choosing to use them. But there's no reason to not use them based on what we've seen so far.
Yeah.
The other thing is considering some adjuncts, things like CoQ10, considering some omnitrope, growth hormone. These are things that we think can help, the machinery of the egg and embryo develop. It doesn't necessarily make you get more, which I don't think you really need more. I think we need a little bit better quality. Also, just for your partner, he may serve well to collect ahead of time and freeze sperm on a day that's not quite as nerve-wracking as the day of egg retrieval. Most guys do fine collecting on the day of egg retrieval, but not all of them do. And those that are super nervous, do it on another day that it's like, if it works this time, great. If not, then we schedule another appointment next week and you collect then, to take the edge off the nerves of performing on the day of.
When you're asking about grading means different things to different people. There are some clinics that are super strict and there are some clinics that are not. And it really depends. Like if your clinic thought that they were good enough to biopsy and freeze, then that really may be all you need, because having a lower grade embryo does not mean you're going to have a lower grade child. It may be a little bit less likely to implant, but in a lot of places, if they thought it was good enough to biopsy and they transfer, and it's a euploid embryo, then you've got a decent chance of moving forward. And so don't put too much emphasis on grading, because it's not always as relevant as you think it is. It's just one piece of data that you can latch onto, which as a patient is incredibly important, because you want to do the best you can. So don't necessarily pay a whole lot of attention to grading.
Yeah, I would definitely second that. I mean, you really want to look at how genetics, because back in the day before we did genetics, which hadn't been all that long ago, that's all we had to go on was how the embryo looked in order to pick the best embryo. And now, like Carrie said, it's certainly a helpful piece of information, but if I had to choose genetics over embryo quality, I'd pick the genetics any day over embryo grading.
The other thing to think of, going back to what Susan was talking about with adjuncts, is there's a bunch of different reasons for hypothalamic amenorrhea. And you didn't tell us what the underlying reason was for yours, but a lot of times it is related to over expenditure of energy and under intake of energy, meaning eat more and exercise less. And it's not often that you have docs telling you eat more, gain weight, exercise less.
That's rare.
That's something to think about if that applies to you. And that is actually extraordinarily difficult to do for many women who are type A, used to being completely in control. And with the emphasis the society puts on body size and image and all the crazy crap. But that's something that's worth thinking about, because it can make a huge difference. And there's not any exact number we can say of, if you eat X calories a day, you will be fine. If you work out X amount or decrease by X amount, you will be fine. It is very much trial and error. And that doesn't sit well with that group of patients who appreciate numbers and exactness. And, something to tuck in the back of your mind if that happens to apply to you.
I have one more question. It's a very short one, and I actually have the answer. So this will be a quick answer for our listener. We don't get many questions that are this short, but we can handle this one. So our question is, in a recent episode, Dr. Hudson mentioned a new PGT test, PGTP. Is there any literature about this? I can't find it anywhere. Thank you for all you do. Love the podcast. So what I would want to direct you to is lifeview.com. This is the website for genomic prediction. You actually can go to the website and they have a header called The Science, and they have a list of publications having to do with the testing validation, embryo health score, origin of aneuploidy or PGTA plus, as well as M2. And it also goes into ongoing clinical research trials. So that's an easy source for you to get kind of the hard science publications.
And you may want to talk to your doctor about it though, because it's pretty complicated and not a lot of centers do it right now either. So, but it's pretty tough even for physicians in this field initially to kind of understand what it is and why we do it and who we would do it on.
And one thing to know is the reason that the three of us all know about it is because the only lab right now, at least that I know of, and if I'm remembering, correct me if I'm wrong, girls, but the only lab system that does it is the Ovation lab system. And that's actually how the three of us knew each other. We met at one of their conferences because all of us have Ovation labs. There's, I don't know, 10 to 12-ish in the country. And we exclusively send to them. And so that's part of the reason why we know about it and why we're up on all of this data and how LifeView is better in many respects because of the way that the program is executed. So it doesn't mean that anything else is bad. It just means that this is the latest and greatest and newest technology, which is really slick.
So interesting.
All right. So today, what we are going to talk about is a small but annoying little problem that we see all the time and that actually provokes a ton of anxiety in patients.
Yes.
And it's polyps. So let's talk about polyps. First of all, what is a polyp? Where do you find it?
So a polyp is essentially an overgrowth of the lining of the uterus. Okay. So as you go through your normal monthly menstrual cycle, the lining is supposed to grow in a very organized fashion. It eventually gets exposed to progesterone. It condenses. We stop the progesterone because you may not be pregnant, and you shed the lining of the uterus. And that healthy cycling kind of keeps the house clean. All right. But sometimes, because of a number of different factors, which we'll probably talk about in a few moments, that process may not happen as well or as efficiently as what it should happen. And we can see these little overgrowths. And these little overgrowths are important because they can interfere with good, healthy implantation. And they can cause some annoying things like dysfunctional bleeding. So heavy bleeding, bleeding at the wrong times, things like that.
So Abby, how do you find out if someone has a polyp or not?
So in our neck of the woods, in our field, usually at least a lot of my patients are asymptomatic. And the only way we find out that they have them is we do a saline sonogram where we put water inside the cavity. We open the cavity up. We're able to see those irregularities there. We can also do a test called an HSG. And sometimes you don't get quite as good a look with an HSG, and it's really harder to diagnose polyps unless they're really big. You can also diagnose fibroids, which can look similar to polyps. But those are basically the two tests that we use to really look at the inside of the cavity. Most of the ultrasounds that we do in our office, like if you had a new patient visit and you had an ultrasound, with those ultrasounds, sometimes we can see an indication that maybe there's a polyp there, but really we have to put fluid in the cavity and kind of, I would say it's almost like putting air in a balloon. We have to blow up the cavity so that we can really see if there's really something in there in between the two layers of the uterus that need to be removed.
And who gets polyps?
Women.
Everybody.
If you have a uterus, there's a chance you have polyps.
That's right.
So, but all joking aside, I mean, people are like, what put me at risk for it? I'm like, well, you got a uterus.
You're female.
You're female. So, but there are people who have higher risks. Okay. So one, if you've had a history of polyps, you're at an increased risk of getting polyps in the future. So if you're, maybe you've done fertility treatment before or something like this, and you've had polyps removed, sometimes people are like, oh, I already had a hysteroscopy. That was 2-3 years ago. And I'm like, well, we need to make sure that we're still okay. So history of polyps is a huge one. Another big factor is people who don't ovulate on a regular basis. So remember, I was talking about that very organized growth and shedding of the lining. If you don't have that happen, even if you have periods, quote, at a normal interval for you. So say you have periods every 40 days, that is not the same thing as having a 28 to 30 day cycle. And so because you're more likely to be breaking off pieces of your endometrium rather than an organized shedding, you're more likely to have some of those overgrowths.
Yeah, and I would add in that patients that tend to be a little bit more overweight are a little bit more likely to get those. And I'm not sure if it's just chronic exposure to estrogen, like Susan said, over a longer span of time. From some really old data, we know in women who took hormone replacement therapy that were postmenopausal, if they took estrogen continuously for more than a year, something like 80% of those women ended up with polyps. So it's probably chronic, just low grade stimulation to estrogen. So those patients really tend to be at higher risk as well. And also our patients that do fertility treatments. I had a patient the other day, unfortunately, that had a normal scan back in the fall, had a normal saline sonogram back in the fall. And then now we saw something on her baseline ultrasound right before she was about to start into treatment that looked, significant for a polyp. And sure enough, when we evaluated her further, she had a pretty good sized polyp. And she goes, well, did you guys do it to me with your fertility treatment? And I said, yeah, probably. Because with fertility treatment, we chronically keep estrogen levels high. And unfortunately, that increases the risk for some people.
So I want to explain a little bit about the chronic estrogen levels that Abby was referring to in people who are potentially overweight. Because a lot of these people may also be like have polycystic ovaries, or they may have diminished ovarian reserve, and they're like, I don't have high estrogen levels. That's part of my problem. Well, the problem really is that your fat tissue produces a form of estrogen called estriol, so E3, whereas what's produced by your ovary is estradiol, or E2. Okay. Your uterus is not picky. It just says, gimme, gimme, gimme. And so if you're always producing that higher level of E3, your uterus is always having that exposure, and that's what's predisposing in a lot of cases.
Exactly. So does having a polyp cause infertility?
Probably not. I mean, there's different layers, I think, that contribute to infertility, and that may be one of the layers. I think it does matter on the size. Size does matter. And certainly if that filling defect that we see in the cavity turns out to be something like a fibroid, that's probably a little bit more likely to cause an issue. We think that polyps can cause chronic inflammation in the cavity, and doesn't necessarily mean you can't get pregnant, but it just means it makes it a lot less likely for you to get pregnant. And so, we're trying to do everything we can to enhance your chances, and taking a polyp out is just one of the ways that we do that.
I would say, I agree on the large polyps. They more kind of act like an IUD, can cause a chronic inflammatory effect that prevents good, healthy implantation. But oftentimes I see it as just like we see a lot of things in fertility. You have a little of this, a little of that, a little of this,
Yeah.
you add them all up together, you end up having problems. I mean, it's just like when we see somebody who maybe the couple has male factor, and the difference in getting pregnant when you're 25 versus 35, that 25-year young egg can compensate for some bad sperm, not as, whereas the 35-year-old egg may not be able to compensate. And this is just another one of those things that, we do occasionally have people who we take care of polyps and then, oh my goodness, all of a sudden they get pregnant. I would say that's the exception to the rule. But like Abby said, it's more like a contributing factor. However, if it is a big one, yeah, that's definitely can be a thing.
Yeah, and just to be clear, polyps are kind of like little bumps in the cavity. I say if you think of the endometrium as the soil, that polyps are like rocks in the soil, kind of just lumpy, bumpy areas. And even if we do surgery and the pathologist doesn't say it's a true polyp, if it's lumpy or bumpy, we want to get rid of it. But one thing couples ask me a lot, or women ask me a lot, is could this block my tube? And generally, kind of like Susan was saying before, generally it doesn't do that. It usually is just kind of one of those things that we try and minimize to give you a better chance of pregnancy, but it generally doesn't cause a blocked fallopian tube.
And sometimes I'll see, though, a polyp that I think probably causes some intermittent blockage if it's positioned just right there at at the ostia that it can contribute, but it's probably not an all or none phenomenon.
Mhm.
It's more likely one that's going to cause you to have a false positive on an HSG, the diatest of the fallopian tubes, and then we resect that and put dye through your tubes, and it's like, whoa, it's open. And we really, you know, we're improving the environment.
That's right.
Exactly. So, okay. So let's say that you see an abnormality on whatever testing is you're doing. How do you get rid of this little sucker?
Well, unfortunately, you have to do surgery. Some physicians will do surgery in the office. We generally don't, mainly because when we take somebody to surgery, it's usually somebody that needs to have an actual procedure where we actually pull the polyp out. And that's a little more challenging if you do an office procedure. So generally, it's called hysteroscopy. It is an outpatient surgery. And I always tell patients, you know, it's the same risk apply as any surgery. It is an outpatient surgery, so pain, bleeding, infection. Generally, though, the surgery is a fairly minor surgery as far as surgeries go. You do have anesthesia, you are put to sleep. And essentially, we put a telescope up inside the uterine cavity where we can actually see, you know, the polyp itself. We don't look at an X-ray picture. We literally can look at the polyp with the telescope. We have another instrument that goes through our telescope, and we can literally grasp the polyp or whatever fibroid and resect it and take it out. And procedures maybe 30, 45 minutes. Recovery times, you know, maybe an hour and a half, 2 hours, depending on how quickly you wake up from anesthesia. And most people feel pretty good within 24 hours, if not sooner. So you don't miss a lot of time away from work.
And the actual polypectomy time is actually, if it's just a
Shorter.
polyp,
Yeah,
it's
quick.
like 10 to 15 minutes. I mean, it takes
Yeah.
you longer to go to sleep and wake up than it is for us
That's
to
right.
do our part.
Absolutely. Yeah. I'm talking all in time. You're right.
Yeah.
It's actually a really quick process.
So that's one hell of a uterus.
So once you see that there's polyp in there and you decide that you're going to do a hysteroscopy, what are the other things that it might be? You know, you get the test back and your doc says, oh yeah, I'm pretty sure this is a polyp. And what are the things that patients always ask us about of what else could this be?
Is it cancer?
The C
Probably
word.
not. Probably not. So we see that
Most likely not.
most likely not. So we see in about 2%, so 1 out of every 50 cases, we have some abnormal cells. Now, most of those abnormal cells are not cancer. They may be precancerous cells that we need to treat with progesterone for a little bit. Okay. And you know, once in a while in a great moon, we do diagnose endometrial cancer. But the thing is we, you know, it's good if it ends up getting diagnosed, because chances are it's early, it's treatable, and you're most likely still going to be able to have and carry a baby.
Absolutely. Okay. All right. I think that covers a ton of the big stuff with polyps. Are we leaving anything out? What are we
Yeah,
forgetting?
one other question I have for you guys, and this is again, you know, we're 3 different doctors. We practice in 3 different ways, but I think we do a lot of the things the same. But you know, it's always hard. Patients always go, okay, I don't have. So I think we would all agree if we saw a polyp that was 8 to 10 millimeters, which millimeters sounds small, but it's big for us. We would probably agree that needs to come out. The tricky part is when you see these little itty bitty bumps in the cavity and you're like, well, is that really a polyp? Should it come out? Should it not? And I always tell patients, you know, I don't really know for sure how clinically significant this is going to be. In other words, is this really going to prevent you from getting pregnant, you know, on your own or with IVF? And I think that's the hard part. I think for me as a clinician, I usually lean towards saying, well, you know, I think now that we see it, we probably ought to go in because we may see even more. And, you know, that way I can look directly at the cavity and really know what impact this has. But, you know, on the flip side, you can argue that it's a surgery. There's risk involved with surgery. And is it something that really needs to be done? So I'm interested to see what you guys tell patients when you find those just little itty bitty kind of incidentalomas that you're like, well, I don't know if it's something significant or not.
When I see those little bitty things, I still want to take them out. And partly just like what you described, you know, we're trying to improve the environment, but also a saline ultrasound to me is good at saying, is there something there? Is there not something there? It is not very good at telling me how much, because I can guarantee all of us have had that saline ultrasound that we're like, ooh, it's a little bit on the edge, but I definitely see a little something there. You stick
Yeah.
in the scope and you're like, oh my goodness, where did all this
Yeah.
stuff come from?
Yes.
So
So,
for people
so
who do in-office hysteroscopy, which we don't, we would normally take those people to the OR.
So when we see all of those tiny little micro polyps, they're actually fairly associated with endometritis. So depending on the circumstances, sometimes we just treat them with antibiotics and then we go back and check, make sure they're cleared. A lot of times they will
Interesting.
be.
You do office hysteroscopy though, Carrie, right?
We do. We
See,
do. So
that's a different.
we have the luxury of just bringing people in real quick, in and out, done, check, and be on their way without messing up their day and without being hugely expensive. And so that's a benefit that we have, because if we had to go to the operating room, I would probably err on the side of removing it. And there's some of it is just gestalt of, this looks like it's a little bit more hyperplastic, I want to get rid of it, versus this looks like it's a very clean, very uniform, and this is probably more just an inflammation that'll respond. But we always go back and check, and if we need to put somebody under anesthesia to get them all out, we'll
So
do that.
we have the capability of doing in-office hysteroscopy, but we kind of decided against doing it because so many times we get in there and look and go, this is really a polyp that we need to take out in the OR. And then they'd go through in-office hysteroscopy and then they'd also go through surgery. And so we're kind of like, maybe we just need to take them to the OR and just look. So that's the only reason why we don't do in-office hysteroscopy, just because we're trying to figure out how that plugs in.
Yeah, a lot of our patients really don't want extra anesthesia.
Uh-huh.
So if they can come in, for a morning appointment and then spend the rest of the second half of their day like
Yeah.
normal, and they can avoid the anesthesia, they really appreciate
Yeah.
it. Plus, that's a good way for us to check the endometritis
Uh-huh.
and say present, not present, because you don't necessarily need to knock somebody out to identify that. And there's a lot
Yeah.
of like cavity contour stuff that it's helpful to take a look at it, because the saline ultrasound is fabulous to know right off the bat if you need anesthesia, but it doesn't tell everything. It doesn't tell everything. So,
yeah.
All right.
Very good.
Very nice. Well, another banner episode of Fertility Docs Uncensored. And to our audience, thank you so much for listening. Be sure to tune in next week for more. And please hit the subscribe button. It helps us more than you know. It also kind of helps us figure out what episodes you want us to do and what information and topics are really useful to you. So we appreciate that as well. Stop by on Facebook, Instagram, and YouTube. Leave us a like, leave us a hello, and push subscribe.
You can also visit us on fertilitydocsuncensored.com to submit specific questions. All questions will be answered on our Ask the Doc segment. And we also want to mention that we have a conference coming up October the 28th of this year, 2023. We hope you'll join us in New Braunfels, Texas. It'll be the three of us and several speakers, and we think you'll get a lot out of it. So we look forward to seeing you there.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.